What are your comments about this great effort that takes place here in Greece right now, about the first conference of cardiovascular imaging in clinical practice?
Well, thank you. Thank you for having me here. And I think it is a very successful and nice congress. It emphasizes that imaging is one of the most important parts in clinical cardiology, because basically not a single diagnosis that we have can be done without any form of imaging, whether it's invasive imaging like an angiogram or it's non-invasive imaging like an echocardiogram. In my practice, every patient gets an echocardiogram. There's not a single one who's not being referred for an echocardiogram. Also, we see more and more the use of CT scans, which we discussed here a little bit already. So you ask me how important is imaging. I think it's very important in the daily practice for clinical cardiologists. And what is nice about this congress, that it highlights the specific topics around imaging, takes it a clinical case-based approach, which is really attractive for the audience, because in daily practice, all of us do case-based approaches. We see the patients, we take the images, we then come to a conclusion. So I think it reflects the real world. It reflects what we see in daily practice. And it's good among peers here to discuss what would you do, how do you interpret this. So I think it's an excellent format.
There is a growing interest in the scientific society about the decision-making and the implementation of the imaging, the cardiovascular imaging in clinical practice. What is the importance in the guidelines from the European Society of Cardiology on this?
I think the ESC guidelines are gaining more and more importance. They're very carefully constructed. We have task forces for each of these guidelines, and actually the guidelines as we have them are very practically oriented. We do not do a specific guideline on echocardiography. We do only guidelines on clinical problems, such as heart valve disease, which is coming, such as heart failure, which is coming now soon, such as ST elevation infarction, such as revascularization. So we take very clinical, big problems that every cardiologist is confronted with on a daily basis. In addition to that, I think these guidelines are more and more based on scientific evidence. So we have more and more class 1 indications coming, although it's still a minority of the total recommendations. Many recommendations are coming from smaller studies, but we see that there's an increasing number over the years of class 1 recommendations. These recommendations are built on multiple randomized controlled large studies. So I think that there's an increase of that. We also see that the physicians are extremely interested and they like to apply it. They like to use it, they like to learn about it, they like to take it home and do it in their clinical practice. One thing that we should always realize is that the guideline is not a law. It's not something that you must do. It's something that advises you in a specific clinical scenario. And the scenario could be different and there could be reasons why you don't follow it or why you choose an alternative approach. What I think is going to be crucial in the near future, and that's what we're going to do, is that we're going to use the national registries. And from the national registries, we will see how patients are being treated in Greece, in Norway, in Scandinavia, in Spain, in Netherlands, in the UK. And based on that, we will see how much these guidelines, built on very specialized randomized controlled trials, how much they reflect the real world. Because sometimes it is like this. For example, if you take heart failure and pacing, we only select in the trials the patients without atrial fibrillation. But we also know that 30 to 40% of the patients with heart failure sooner or later develop atrial fibrillation. So guidelines are nice, but they do not always reflect the real world. And so what we're going to do is that we're looking at the guidelines, we look at the implementation, but we also look at these registries, real world evidence, how they would actually affect guidelines. So we have this continuous loop. The guideline, the practice, the registries, which is the practice, feeding back to the guidelines. That's the project that Alek van Jan is going to do in the next couple of years.
And how can all this plan be less cost-effective for the patient and, of course, with less radiology? It's very crucial, I think.
Radiation is important. Radiation is a key issue. With the CT, you can get very specific images. So we have MRI scanners. We can use those. There is no radiation, but the MRIs are very complex in the way you use them. So if we have the daily practice, we use mostly echocardiography, which is sufficient in most of the patients. So I think echo, as we started our conversation, is key in this. I think also in the practice the patients need imaging, but they don't need every imaging. So it is the issue for the doctor to think, okay, this is the problem. What information do I need? What sort of imaging do I need for that? And then I get the information, and then I will use that to treat the patient. If we can integrate the clinics with the imaging and the decision making based on that, then I think we're on the right way.